let's move on to the cardiovascular system. Cardiovascular system are going to have two different types of tissue. First is going to be the nodal tissue and the second is going to be the cardiac muscle cell. Now please remember, the nodal tissue, you don't tell your heart to contract right now, relax right now, contract right now. So how it is going to contract on its own? Because of the property of autorhythmicity. What is auto? Auto means on its own. How that is possible? So please remember, the RMP is fluctuating. How does it fluctuates? So let's see. From minus 60, it is going to go towards minus 40. From minus 60, it is going to go towards minus 40, right? And as soon as it goes towards minus 40, then this is going to be called as the firing level, from where the action potential is going to fire up. Now let's see how this is going to take place. So this slope is known as pacemaker potential. Please don't get confused between the pacemaker potential and action potential. The whole thing that I have drawn over here, that is known as action potential of the nodal tissue. But from minus 60 to minus 40, it is going to be called as pacemaker potential. And three ionic changes are responsible for that. We are going to remember that via a mnemonic, that is funny cat pick. What is funny cat pick? Please remember, funny means funny sodium channels, or which are also known as leaky sodium channel or HCN gated sodium channel, that is hyperpolarization activated cyclic nucleotide gated channels. Nobody will ask you. Just remember, if you want to remember, that these are hyperpolarization induced or hyperpolarization activated, alright, or these are also known as funny sodium channels. So funny sodium channels are going to open up, or we can say they are automatically, it is going to leak into the cell, right, or cardiomyocyte. Now what will happen, that because the sodium is leaking inside the cell, the positivity will come inside the cell, negativity or potential will become a little bit positive. But that was not sufficient. We wanted some more potential, so we are going to open up the calcium T channel. What do you mean by T? T means transient. For very short duration, they are going to open up, and that's why we call them as transient. Then pick. Remember, this is a little tricky, that P is for potassium. P for potassium, right? Potassium immediate closure, or you can remember it as potassium early closure. What happens in this? That usually I told you that the potassium, K for kachwa, that is tortoise. Potassium closes slowly. But that is not in the case of nodal tissue. They are modified one. So what happens? Yes, the calcium is also going to come inside, but as soon as I talk about potassium, they are going to close early. So what will happen? The potassium will not be able to go outside the cell. They will accumulate inside the cell. So all three ions are positively charged ion, and they are building up inside the cell. So the potential of the cell will go towards the positivity, that is from minus 60, it is going to go towards the minus 40, which is the firing level. As soon as we reach to the firing level, what will happen? As soon as we reach to the firing level, there are another calcium channel, that is calcium L channels, which are going to open up. L means long acting. So compared to calcium T channels, they are opened for the longer duration. So that's why we are going to call that as calcium long actin. Till what point they will be open? They will be open till plus 20 to plus 30 MV. In different books, different values are given. In some books, it is given as plus 35 also. I am writing on an average, it is going to be plus 30. Alright. That is known as the spike potential. Whenever we reach to the spike potential, we always do two things. What are those two things? First of all, whatever channel is open, close that channel and open potassium. So as soon as I'm going to open the potassium channel, what will happen? Definitely the potassium efflux will start and the repolarization will occur. So this is about the action potential of the you can say nodal tissue. As soon as we are going to reach to minus 60 back again, what will happen? As soon as we reach to the minus 60, again those changes will start and again new beat will be started. Alright, so that is about the nodal tissue. As soon as nodal tissue produce the action potential, what will happen? This action potential is mainly produced in the pacemaker cell. Normally in healthy person, it is the SA node, will be forwarded to AV node, bundle office, bundle branches and Purkinje fiber. Finally, the Purkinje fibers are going to stimulate the cardiac muscle cell and new action potential will be formed in the cardiac muscle cell. Let's see what is the cardiac muscle cell action potential. And how it looks like. This looks something like this. As soon as the Purkinje cells are going to stimulate my cardiac muscle cell, what will happen? There are going to be sodium channels which are going to open. So sodium influx will start. As soon as the sodium influx started, it is going to reach to again plus 30 to plus 35 MV. That is nothing but the spike potential. We all know as soon as we reach to the spike potential, we are going to do two things. Whatever channel is open, close that channel. That means I'm going to close the sodium channel will be closed. And I'm going to open the potassium. So please remember over here for the short duration, the potassium channel, only potassium is going to be open, and that's why they are known as transient opening channels. Alright. But please remember the potassium efflux will never stop unless and until we reach back to RMP. RMP is going to be minus 90 over here. Minus 90 over here. And unless and until I reach back to RMP, this potassium efflux will not stop. That means the potassium efflux will continue here also, and the potassium efflux will continue here also, and the potassium efflux is also going to continue here. But here specifically the inward rectifier channels are going to be open, if you want to remember the subtype of it. Alright, now what will happen is that the potassium channel is open, okay fine, but how does the plateau is coming? That means how does the flat line is coming? It should have repolarized quickly. But as soon as the potassium transient opening channels are opened, after some time, there is one more channel which is going to open, which is called as the calcium channel. So calcium influx will start over here. But calcium's channels, they are not that stubborn, so they are going to close, and these are calcium L channels only, right? So L channels, they are going to close after some time, and because of their closure, what will happen? Again the potassium will continue to go outside, and that will cause the repolarization. So repolarization is divided into two phases: early repolarization and late repolarization. Alright, now let's talk about the very specific phase in which two ionic changes are happened, or two ions float in or out of my cell, and that is nothing but the potassium and calcium. So please remember over here what is happening is that two ions are moving at a time. So this is nothing but the phase 2, and one positively charged ion going outside, one positively coming inside. So they will almost balance each other and balance the potential of the membrane, and that's why the flat line will come, which is known as plateau. So how to remember plateau? Phase 2, two ions are going to move. Alright. Then before 2, which phase is going to come? So this is the 2 repolarization. That is the first repolarization is phase 1, and before that we are going to have phase 0. Please remember depolarization is phase 0. It is not phase 1. Alright. And please remember after plateau only potassium will continue. That is phase 3, and RMP is always phase 4. Don't get confused between phase 0 and phase 4. Phase 0 is depolarization, 4 is RMP. Let's move on to the order of activation. Nothing fancy in this. Just remember that Purkinje fibers, they are going to have maximum gap junction. That's why they do have maximum velocity. The direction of depolarization is from endocardium to epicardium, and the direction of repolarization is going to be reversed. That is from epicardium to endocardium. Right, just remember that. And the last part to be depolarized only once. This has been asked in the NEET. So please remember the last part to be depolarized is going to be posterior basal part of, or posterior basal portion of the left ventricle. So if I draw the ventricle like this, suppose this was the ventricle, right? So this part is known as posterior basal part of the left ventricle. This will be the end part to be depolarized. Then if that is not in the option, then go with this. This is second last to be depolarized, that is pulmonary conus on the right hand side, or the right ventricular basal part of the ventricle. Alright, so that is known as pulmonary conus. And third last part to be depolarized is going to be the left part of interventricular septum. So this is going to be the third last part to be depolarized. Right? So second last and third last. Last is going to be posterior basal portion of the left ventricle. Let's move on and let's see what your heart says. Your heart just says 1, 2, 3, 4. That is the sounds that we are having, S1, S2, S3 and S4. Please remember these two sounds, that is S3 and S4, they are normally in the healthy person, it is going to be less than 20 Hz. So that's why for the normal human ear, it is not audible. Why? Because our auditory range is going to be from 20 Hz to 20,000 Hz. Alright. Now, how the first heart sound will be heard? Please remember, the valve closure will always make a sound and not valve opening. So, the first alphabet is going to be A, AV valve closure. That is going to give me S1 sound, that is atrioventricular valves. What are the atrioventricular valves? On the right hand side, we are going to have in the right atria and ventricle, in between we are going to have the tricuspid valve, and similarly on the left hand side, in between the left atrium and left ventricle, we are going to have mitral valve. Alright, so their closure is going to make the S1 sound. S2 sound, semilunar valve closure will make the S2 sound. So how to remember? S for second, S for SL valve closure, that is semilunar valve closure, that is nothing but aortic and pulmonary valve closure. And please remember, the ventricular filling is going to make third and fourth heart sound, that is the S3 and S4. The early filling is going to make the S3 sound and the late filling is going to make the S4 sound. Alright, so early and late filling. Early and late filling, they are abnormal in all the males, but if the female is pregnant only, this is the only one physiological condition in which the heart sound, S3 sound, can be heard normally. This is the only physiological condition. It can be heard in the CHF, it can be heard in the anemia condition, but these are hyperdynamic conditions which are pathological. This is the physiological condition. The S4 sound is always abnormal even in the pregnancy. Now let's move on to the cardiac cycle. One cycle consists of systole and diastole. That means one contraction followed by relaxation is known as one cardiac cycle, which accounts for 0.8 seconds. In the atria, the systole is for 0.1 second and the diastole is for 0.7 seconds. That means the heart chill out for more time. Alright, it does the work only for especially the atria, it is going to do the work only for the 0.1 second. Right, and ventricles, the systolic time is 0.3 seconds and the diastolic, during the rest, it is going to be 0.5. If I say, these are the approximate values, but if I say exactly, it is going to be 0.27 and 0.53. That means if I draw a 24-hour clock, then only for 8 hours, my heart is going to be in the systole and rest of the 16 hours, it is going to be in the diastole. That means double the time it relaxes. Alright, so please remember that. Why? Because when we are going to calculate the mean arterial pressure, at that time this is going to be very helpful. How to calculate the duration of cardiac cycle, how this 0.8 seconds come from? So please remember the formula, that is 60 upon heart rate. 60, that means in 1 minute we are going to have 60 seconds and upon heart rate. So please remember, if something is in the denominator, it is going to be inversely proportional to the ratio. What I mean by that? Let's say that the heart rate, normally ideal heart rate, right? What is it? That is going to be 72 beats per minute, and that is going to give me around 0.8 seconds. That is going to be the normal value of cardiac cycle. If I increase the heart rate, let's say I did it 100 instead of 72, it is going to be 0.6 seconds. That means the cardiac cycle duration has been reduced, right? And if I decrease the heart rate, I'm going to get whole 1 second for the contraction and relaxation or the diastole of the heart. Alright, so please remember that. Now let's see what are the phases of the cardiac cycle and what are the phases specifically of the systole and diastole. So first of all, I want you to remember this phenomena, that from S1 to S2, whenever my heart goes from S1 towards S2, this will be called as systole, and when it goes from S2 to next S1, it will be called as diastole, and these are the two phases because of which the cardiac cycle is formed. Right, now we are going to start with the S1 and we are going to go towards the S2 for the systole. S1 to S2. Alright, now I'm going to divide that into 3 phases, that is early, mid and late. Early, mid and late. This is early systole, mid systole and late systole. Don't get confused that with the ejection. Alright, now First of all, whenever I'm going to say that it is the systole or diastole, please remember first phase is always going to be isovolumetric phase. Now, why it is isovolumetric phase? Look over here. What happens when any phase is starting, whether it is systole or diastole, both the valves will be closed. And if both the valves will be closed, what will happen? There will be no change which is going to take place. Now, I want to do the systole of the heart. That means I want to contract the ventricle. Whenever the ventricle started to contract, what will happen? There will be ejection. But there is a little bit problem. What is the problem? The issue is that during the end of the diastole, my ventricle is going to have almost 0 to 5 or 7 mmHg of pressure. We can take it at 10 also. And the aorta is having 80 mmHg of pressure at the end of diastole when the systole is about to start. And there is a prerequisite of this valve, that is the aortic valve, or if we talk in terms of right ventricle and right atria, it is going to be the pulmonary artery. What is the prerequisite for the opening of SL valve? That is nothing but the ventricular pressure must be more than the aortic pressure or the pulmonary artery pressure in case of right ventricle. But it's the vice versa case. Let's say the pressure is 10 over here. How can I increase the pressure? I am going to ask the ventricle to contract. As the ventricle started to contract, the pressure is going to rise to 20, 30, 40, 50, 70, 80 finally. But still it is not more than the, you can say, aortic pressure. Now, during this time, when the pressure was going from 10 mmHg to 80 mmHg, during that time, the ventricles were contracting. But please remember, there was no filling of the ventricle or no ejection. That means blood was not moving anywhere. So the volume of the blood inside the ventricle was same. And if it is same, we are going to use the terminology iso, and we are talking about volume. So isovolumetric contraction. And because of that isovolumetric contraction, after some time, this prerequisite will be met, and which valve will be open? At that time, this SL valve will be open. SL valve is nothing but your aortic valve and the pulmonary artery, that is the pulmonary valve. They are going to open. As soon as these nice little valves are open, what will happen the next? The next thing that is going to happen is the ejection that is going to start. So please note it down that the ejection will start. Now this ejection is going to have two phases. First early ejection and then the late ejection. During the early ejection, my ventricular constriction or contraction is continuing, and please remember, because of that, this phase I'm going to call it as active phase because of the ventricular contraction, I'm using the ATPs. Alright, and this is going to be very, very rapid because of the contraction. 2/3 of the blood volume will be ejected outside of the ventricle. Now let's talk about the late phase. Late phase is going to be passive. How come? It is going to be passive and it is known as slow. Only 1/3 blood is going to be given out of the stroke volume. Please remember, whenever you drive a vehicle, what happens is, if something comes in between your vehicle and the road, what happens? You put the brake. Your vehicle will stop at that point, but because of the momentum that gained by your body goes forward and then it's come back. So that is known as momentum, and because of the same momentum which is gained by the blood keep on moving outside into the aorta from the left ventricle. And that's why it is called as passive, because I'm not using any more ATPs in the late phase of ejection. I'm not doing any specific ventricular contraction for that phase. Alright. And then what will happen once the stroke volume went outside? Now my heart, my ventricles started to relax, but as soon as ventricles start to relax, aorta get to know that now the ventricular pressure is decreasing. So what it will do? This prerequisite of the semilunar valve is no longer met, and suddenly what will happen? The semilunar valve will close. Semilunar valve will close. So semilunar valve closure, and the semilunar valve closure, of course, it is going to cause the second heart sound, and that's how our systole is going to be completed. Systole is going to be completed. Let's come on to the diastole. I just now told you that as soon as the stroke volume went outside, what will happen? That of course the semilunar valve start to close. But please remember, there will be a short duration, that is 0.04 second. 0.04 second. For that duration, the heart muscle, the ventricles, they were relaxing, but the semilunar valve was not completely closed. Please remember, it is not a proper diastole. The proper diastole is going to start from S2 and it is going to go towards S1, right? But before that, this phase has come 0.04 seconds. So that is nothing but when the SL valve, semilunar valves were still open and my ventricle started to relax. Since the ventricle started to relax, I'm going to call it as diastole, but it was not proper diastole. It came before the proper diastole, and that's why I'm going to call it as protodiastole. Alright. Now, finally the S2 will come, that is the SL valves are going to close, and again I'm going to divide the systole also and diastole also into 3 parts, same as systole, that is early, mid and late diastole. Alright, in the early, same thing is going to happen. We have drawn the atria, ventricle and aorta before also, and I told you that beginning of all the you can say phases, there will be closure of the valve that is going to be there. Now I have to do the filling, right? Filling of the ventricle. So filling of the ventricle, for that I need to open this AV valve. But it is also having one prerequisite for the opening. And what is that prerequisite? The prerequisite is that the atrial pressure must be more than ventricular pressure. Then and then only this AV valve will be opened up. Now, the ventricular pressure at the end of systole, it is going to be very high, that is 120 mmHg, and it is almost 10 to 25 mmHg, which is going to be there in the left atrium. Please remember, at this point, I need to open up the AV valve. So, what should I do? I cannot increase a lot of pressure in the atria, but I can decrease the pressure inside the ventricle via asking them to relax. Now, the ventricular relaxation will start, and from 120, the pressure start to decrease. The pressure will come down to 110, 100, 80, 70 like that, and finally it will come down to 10. But still, if it is 10 and 10, the AV valve will not open. At this point of time, that means during this phase, the early phase, the relaxation started to occur, but please remember, the volume in the ventricle has not changed. So again, this phase will be called as isovolumetric phase, but at this time, the ventricles are relaxing, and that's why I'm going to call it as isovolumetric relaxation. At the end of isovolumetric relaxation, eventually the pressure inside the ventricle will become 9, 8, 7, 6, 5, 4, 3, 2, 1 like that, and finally this AV valve is going to open up, right? So AV valve, they are going to open up, right? And if they are going to open up, after that, what will start? The ventricular filling will start. It is divided into 2 parts, early and late. Please give some space in between. We are going to write something else also here. Early and late phase. Please remember, in the early phase, what happens is that the pressure gradient is already there. That means, let's say over here, the pressure in the ventricle in the beginning of the diastole proper, it is going to be 0. So there is a gradient of pressure which is going to be present, and if the person is in the erect position, that means standing or sitting position, what will happen? Definitely the gravity is also going to help, and blood is going to come from the atria towards the ventricle. So again, the position, the gravity is also going to help me out, and because of that, please remember, this is going to be the passive ventricular filling that is going to take place. All right, the passive filling is going to be rapid filling. Why? Because of the pressure gradient and gravity. Please remember that. Eventually what will happen? The filling will start, and as soon as the filling of the blood will start in the ventricle, ventricular pressure is increasing and the atrial pressure is going to decrease. There will be a point where these pressures are almost negligible. So almost no blood is going to flow from the atria into the ventricle. Some flow is going to be there, but it is negligible. It looks as if no valve is opening, closing, no volume change is occurring, right? So it looks as if the heart has stopped in the diastole, and this phase is known as diastasis phase, right? It is the best phase if you want to measure the thickness of the myocardium or the valve lumen, right? So diastasis. So please remember, in this, slow filling will occur, somewhat filling will occur, it is almost negligible. Combinedly, these two are going to fill the ventricle 2/3 part, or some books also says up to 80% it can be filled. And the late filling at this time, it is also going to be active and it is also going to be rapid. How this is possible? Because during the late part, now the pressure gradient has vanished. I need to still fill the ventricle, whatever venous return the veins have got into the atria. So the atria start to contract and build up more pressure, and the pressure gradient eventually. So please remember, 1/3 or some book says 20% is going to be filled into this phase, right? And finally, as soon as complete filling occurs, then the AV valves are going to be closed. And I told you, as soon as we are going to close the AV valve, S1 sound will come. And that is all about the systole as well as diastole. Please remember. Coming to the JVP, which is also known as jugular venous pressure or central venous pressure, and it is the representative of right atrial pressure, right? It is going to have 3 waves, 2 descents. Upward stroke, waves, downward stroke, descents, right? 2 descents are X and Y, 3 waves are A, C and V. Please remember, A wave is for atrial. A wave comes because of the atrial contraction. And I told you that the atrial contraction, if that is happening, that means it is the late filling phase of the ventricle that is going on. So I'm writing late ventricular filling that is happening, right? In the red color, I'm going to write the ventricular events. On the other hand, in the blue color, I'll be writing what is happening in the atria. All right. Now, if I talk about C wave, why the C wave comes? What happens is, at the C wave, the IVC is going on. That means, please remember, C for C, IVC, isovolumetric contraction is IVC. During the isovolumetric contraction, the SL valve, they are closed, but the ventricles are contracting, and because of that, what happens is, whatever tricuspid valve is there, it is going to bulge into the right atria because of the pressure building up into the ventricle. So now what will happen? Of course, the right atrial pressure is also going to increase, and that is because of the bulging of tricuspid valve. I'm writing it in the short form, that is TV. I'll write this in the red color because this is the ventricular phenomena, right? Please remember, C for C, that is isovolumetric contraction. Bulging of tricuspid valve where? Into the right atrium. Because of that, slightly upward stroke is going to be there, that is C wave. Now what will happen after that? In the ventricle, the ejection will start. Ejection will start, and this whole phase is known as X descent. Because of that, what will happen? The pressure inside the atria is also going to decrease, and I'm going to have that X descent. If they specifically ask about X, it is the complete from the A towards the X. So because of that, the complete atrial relaxation will occur, and atrial relaxation is going to give me the X descent. Atrial relaxation. Please remember it as this, X for X, alright? And atrial relaxation is from the A towards the X, the complete descent. In between, I'm going to have that C wave. But specifically, if they ask about X dash, that is going to be this phase. It is because of the tricuspid valve coming back, or tricuspid TV returning back, when it is going to return back to its normal position. Because of that, I'm going to have X dash if they specifically ask about it. Alright. Then I have the V wave. V wave is going to be because of the, in that time, I'm going to have protodiastole plus IVR. So please remember, V is for VR and IVR, right? IVR is isovolumetric relaxation and VR is venous return. Right? That means atria is actually getting filled over here. I can write it as atria filling, but it is easier to remember from V by V. That is IVR and VR, they are going to come at V wave. Alright, IVR is isovolumetric relaxation, which is the ventricular phenomena, and the VR, which is going to be the atrial phenomena. Alright, then what is going to happen at Y descent? Y descent is because of atrial emptying. That means the atria is getting emptying passively into the ventricle. So that is going to be the early filling. Early filling of the ventricle. So I'll write it as early ventricular filling. That is going to be from the V to Y, that is Y descent. During the Y descent, what is going to happen? Of course, it is going to be the ventricular phenomena that can be seen.